This lecture is going to be on musculoskeletal disorders. So a couple of reminders about bone physiology. Bone is made of both organic and inorganic substances. So the organic substance, this is things made by your body. This is living tissue. This is your matrix. And the inorganic substance are the minerals, the calcium and the phosphate, that create the hardness of the bone. Both the organic and the inorganic are required in order to have strong bone. Makes it strong but flexible. If we think about the cells involved in maintaining our skeletal system, bone is built by osteoblasts, B for building, B for blast. So blasts build bone, and bone is broken down by osteoclasts, C for crush, C for clast. And these two sets of cells are constantly in a teeter-totter to remodel your bone based on how it's used and what sort of pressure is put on it. So if you're spending a lot of time using particular bones, or you're doing weight-bearing activity, your osteoblasts are going to be working to build that bone. And if you're more sedentary, or if you need some calcium, your osteoclasts are going to be breaking down bone. And if these two cells are not working in alignment to meet the physiological needs of the body, this is when we can have problems with disease. There are some basic diagnostic tests that can be used to assess bone, joint, and muscle diseases. The obvious ones are some imaging ones. X-rays show bone. Other imaging techniques such as MRI and CT scans can also show structural components of the bones, muscles, and joints. Fluid from inside the joints can be aspirated, and we can look and see what's in there. Electrical recordings can be done using electromyography from skeletal muscles to see what's going on with the skeletal muscle. And like always, biopsies can look at the histology of any given tissue. All right, we've got some hormones that are going to affect bone. They affect bone indirectly because all of these impact blood calcium. Blood calcium is the actual regulated component of all this, and our bones just serve as a reservoir to either hold excess calcium or release calcium when we need it for our blood. But as hopefully you recall, parathyroid hormone is going to raise blood calcium, and it does this by pulling extra calcium from the intestines, by preventing calcium from being excreted from the kidneys, and also from breaking down bone and releasing calcium into the bloodstream. The opposite of this is calcitonin, or the antagonist of this. Calcitonin is going to decrease blood calcium, and it does this by stopping or preventing bone breakdown. We know vitamin D is really important for our calcium. We go out in the sun to get our nice vitamin D. It's going to increase blood calcium by increasing our intestinal absorption of it. So if any of you guys take supplements of calcium, you might consider also taking vitamin D with your calcium. So there are a number of different conditions that can affect the bone and cause disease. We'll look at some infectious ones. We will look at bone and mineral and vitamin deficiencies. We will look at atrophy or degeneration of joints, and we're not going to discuss tumors today. All right, so our first thing that we're going to consider relative to bone is a traumatic injury, which causes a fracture. A fracture is any disruption in the continuity of a bone, so this basically just means a broken bone. Okay. In most cases, fractures are caused by some sort of sudden injury, but occasionally there are also what are called stress fractures. Stress fracture is when there is incompatible stress with the structure of the bone. So this comes in two varieties. So we can have a fatigue stress fracture, which is when you have too much stress on what would be normally considered healthy bone. Sometimes this happens in unconditioned athletes. For example, if you've ever had shin splints, the really painful pain in your shins after running too much when you're not really used to it, that's a fatigue stress fracture. There are also pathologic stress fractures. This is when you exert what would be normal stress on a diseased bone, and that causes the bone to break. So we might see this in conditions where bone is weak, and then just a normal incident would cause a broken bone. So there are a lot of different ways that we can classify fractures. We can classify it based on where it is, the type, the direction, the pattern of the fracture line. The ones we're going to worry about in this class would be an open or compound fracture versus a closed fracture. What this means is an open fracture involves a break in the skin. An open fracture is the same thing as a compound fracture, and we have broken through that first line of defense. Bones can also be broken and have no skin broken around them. Obviously, an open or compound fracture is going to come with a greater risk of infection. We can also talk about complete versus incomplete breaks. So, for instance, a transverse break or an oblique break are complete. The bones are dissociated from one another. Sometimes in like a spiral fracture where it's just twisted around due to a twisting motion, it's not a complete break. The bones are still in relatively the same position. And really what we see in terms of manifestations of a fracture are visible bone misalignment. There's a significant amount of pain associated with a broken bone, and the area will be swollen, probably bruised, and potentially bleeding inside or outside. Because of the swelling and pressure on the nerves, there may be numbness and tingling, and this may limit mobility. So bones can heal themselves if they are positioned appropriately, which we'll talk about. There are 4 stages that we think about with bone healing. The first stage is hematoma formation. A hematoma is just a blood clot. So after you break the bone, it is going to bleed because bones have blood vessels. And this blood is bringing all of the good things that are needed to heal the bone tissue. There are clotting factors, there are inflammatory cells to clean up the mess, there are growth factors to encourage new growth of new cells. So all that good stuff in the first couple of days is part of the hematoma. The second step is called the formation of a soft callus, C-A-L-L-U-S. This is a type of granulation tissue, which is that healing soft tissue that comes before true healing occurs. This is going to involve deposition of cartilage. We're going to have fibroblasts and osteoblasts starting to reconstruct bone, and we connect the 2 pieces of bone together. So they are now reconnected with the soft callus. In the third step, we form what's called a hard callus. This is where we begin to ossify the bone or deposit the calcium and phosphate, the mineral salts, into the bone. And this is going to cause mature bone to be formed. So as we ossify across the broken or damaged part of the bone, that's going to be a more secure and permanent healing of the fracture. The last thing that happens is we kind of have to clean up our mess. We're going to have bone remodeling. So any place we laid down extra bone, we're going to resorb that. And just beginning to use the bone again, you'll begin to, the normal stress on the bone is going to cause the bone to come back to its normal shape and size. Obviously, younger folks are going to heal more quickly than older folks. That's kind of how it happens. But again, this does happen. The body can heal itself in this way. So it's diagnosed, as we've indicated, with an X-ray. That's kind of the gold standard for diagnosing a fracture. To treat it, the first thing you want to do is what's called reduction. You need to get the fractured bone back in its anatomical position. As we said, the bone can heal itself as long as you put the pieces back where they're supposed to be. So once you've reduced the fracture, you need to immobilize it. You need to keep things from moving about. So this can be done with a cast or a splint or even surgically with some pins in order to prevent that bone from moving around and allow the body to heal itself. And then hopefully the process of doing this will preserve and restore the function. There are some potential complications that come with fracture. We'll look at some of them on the next slide. But breaking bones and sending little chips of sharp things through the body can lead to nerve damage, bone damage, and atrophy to the muscles while they're sitting in a cast. Some additional complications of fractures include fracture blisters, which are just skin blisters in the area of the epidermis. Having a cast on like that can be very damaging to the skin, and you can kind of get some necrotic tissue in there. Another complication is something called compartment syndrome. If you look at the cross section of, we have a bone here and we've got several muscles, we've got nerves coming through here, we've got blood vessels, arteries and veins. We have a lot of things going on, and then we have connective tissue and skin surrounding it. Now the connective tissue around it, the fascia, can be kind of tight. So particularly if we end up with swelling due to bleeding or to the inflammation that's happening, all that pressure is going to be compressing the components that are inside this compartment here, and that can compromise the circulation. And that's what we refer to as compartment syndrome. In that case, you would need to slice it open and relieve the pressure. Something else that can happen is a fat embolism syndrome. This is where little fat droplets from the tissues get dislodged and find their way into small blood vessels. This can be dangerous depending on where they decide to lodge. In the pulmonary system or the brain, always are not good ideas. But they can also just cause skin and mucosal petechiae, which are little speckles of bruising. Osteomyelitis. This is a bone infection that can occur after an open fracture. So obviously if you have broken down your first line of defense, you've increased the risk that pathogens can get in. Anything that is osteo means bone, and so osteomyelitis can result. All right, our next disease of bone is osteoporosis. The definition of osteoporosis is it is a metabolic bone disease where bone density is reduced. What happens, and you can really see it in this picture here, so this is normal bone on this side, and this is osteoporotic bone on this side, and you can really see that it's very porous. You can imagine that this would be very fragile and easy to break. So we said at the beginning that if you have normal, healthy bone, your osteoblasts and your osteoclasts are working in conjunction with one another. They're balanced in order to leave you with healthy bone. In the case of osteoporosis, your blasts that should be building bone are not pulling their weight. They're not keeping up. So we're breaking down bone at a faster rate. The weight-bearing bones, the hips and the vertebrae, tend to be most susceptible and also most commonly broken with osteoporosis. So how does this result? We said it's an imbalance. So we've got down here, we have the osteoclasts in blue breaking down bone, and we have the osteoblasts building bone, and we just have the clasts working harder than the blasts. All of us achieve our peak bone mass is in young adulthood. as we grow older, our bone mass diminishes, particularly in women. So there are a number of risk factors that can increase the risk of osteoporosis. As I mentioned, being a female is a big risk factor, being of advanced age. And by advanced, I mean postmenopausal. The estrogen that is circulating in the body prior to menopause protects bone. So after menopause, when estrogen levels decrease, individuals are at greater risk, females are at greater risk for osteoporosis. The ethnicity, individuals of Caucasian and Asian descent are at greater risk of osteoporosis. Individuals that have a smaller bone structure to begin with are at increased risk, and also a family history. Modifiable risk factors that increase the risk of osteoporosis are being sedentary. Being sedentary increases bone breakdown no matter what, and that's not what's needed when you have osteoporosis. Having a calcium and vitamin D deficiency increases the risk of osteoporosis, as well as a high protein diet, excessive alcohol intake, excessive caffeine intake, and if you haven't quit smoking yet, you might as well. It's a risk factor for about everything. All right, so what does this look like? Here's our lady with osteoporosis here, and we can see a couple of things. Number one, she may have a decrease in height. Part of that's just compression of the intervertebral discs, but part of it is this dowager's hump, as it's called, this kyphosis or bending of the back in this way. And she is going to be at much increased risk of fractures, particularly in the hip and in the radius. Most of these would come from falls or compression fractures of the vertebrae. So you can definitely see in this x-ray, here is a normal x-ray of the hip, and you can see the decreased bone density. So how do we diagnose it? Well, we can look at patient history, but one of the main things is the bone density testing. This is done primarily in women or in men with risk factors, again, after menopause, using dual energy x-ray I can't say that, a DEXA scan of the hip and spine to assess bone density. In addition, to go to the doctor and they measure your height and weight every time, they would be looking at decreasing height and then determining whether you have additional risk factors. If you've got it, what do you do about it? Well, the best way is to try to prevent it, figuring out who's at risk. Individuals who have not been diagnosed with osteoporosis, they can engage in regular exercise, particularly weight-bearing exercise, because that will strengthen bone, and make sure they have adequate calcium and vitamin D intake. If osteoporosis is diagnosed, there are drugs and hormones that can help reverse that backwards cell function process, so they would inhibit resorption and stimulate bone deposition. And then in general, individuals with osteoporosis, you want to reduce their risk of falls, and if they need some sort of rods or things to sort of fix fractures or brace the spine to help prevent breakage there. All right, next one is a quick one. We're going to look at osteomalacia. This is a softening of the bones due to inadequate mineralization in adults, so lack of calcium and phosphate. So again, this can be caused by low calcium absorption or low vitamin D, which allows us to absorb calcium, or also this can result after renal failure, because renal failure can lead to a deficiency in phosphate, and we need both calcium and phosphate to make hard bone. The incidence of osteomalacia is higher in elderly patients, in places where it's cold, which may have something to do with the sunlight amount in the vitamin D, and people who are taking long-term anticonvulsants. The way this manifests is through bone pain, tenderness, and pathologic fractures, so fractures of normal stress and diseased bone. It's diagnosed with x-rays, bone scans, and biopsies of the bone. And you treat it with nutritional supplementation or fixing the cause if you can. All right, arthritis in general just means that you have disease of the joints. It tends to limit mobility and cause pain. We're going to talk about two main types of arthritis. The first is osteoarthritis. This is the wear and tear arthritis that we all get because we all age. So it's just joints degenerating because we use them. The other type is rheumatoid arthritis. This is a true autoimmune disorder, and it affects the joints, but also there are full systemic effects as well. So this is just a reminder of what a synovial joint looks like. You have two bones in apposition. Each of these is going to be covered with articular cartilage. So we've got that on both sides, which is a softer sort of padding for the bone. And then it's connected. Joints are connected by ligaments. And then there is a fibrous joint capsule around it. And they're filled with synovial fluid. This is the lubricating juice that keeps the joints from having too much friction. All right, in the case of rheumatoid arthritis, this is a chronic autoimmune systemic disorder. And what's being attacked, the autoimmune part, what's being attacked is immune cells in that synovial cavity in the joint, and you're destroying articular cartilage and bone. Because it's autoimmune, it tends to affect women more than men, and we know that the onset is kind of in middle age. So what do we have going on here? We know it's autoimmune, and so actually what gets involved here are helper T cells. They release these inflammatory mediators that tend to destroy the joints. So if you are predisposed and you have some sort of trigger to start this process, your T cells are going to respond and start making this rheumatoid factor antigen, which will interact with your antibody, your IgG. Complement comes to the party, cytokines are produced, and there is significant inflammation. Inflammatory cells are also coming, which release enzymes and prostaglandins that chew up the cartilage and the bone. Okay. The inflammatory response, because your body does this when it's trying to heal, can also cause inappropriate growth of blood vessels and some of the synovial cells, where we begin to have angiogenesis, which is growth of new blood vessels, and some of the synovial tissue will proliferate and make more of itself, and this creates what's called a pannus. So you have a pannus invading the joint. So here's our gal with rheumatoid arthritis. One of the key features that we think about with rheumatoid arthritis is symmetric joint involvement. So both sides of the body are experiencing the same thing. Rheumatoid arthritis tends to start with the smaller joints, particularly in the hands and wrists, and there are some very characteristic features of what the joints look like when they're inflamed. So some people call this a boutonniere thumb, this ulnar deviation. This woman also is experiencing arthritis in her shoulders, but again, it is symmetrical. And because she has these inflammatory chemicals circulating in her body, she experiences fatigue, weakness, and anorexia. She may see inflammation in other places. So she may see neck discomfort due to the problems with the spine, lymphadenopathy in the lymph nodes. She may see involvement of other organs, so there may be pleural effusions, pericarditis, nephropathy, splenomegaly. She will see elevated ESR and CRP due to the systemic inflammation. So just inflammatory processes going on all over. So this is diagnosed with a history, physical, and then the criteria from the American College of Rheumatology. To diagnose RA, 4 criteria are present for at least 6 weeks. And the choices of criteria involve morning stiffness, morning stiffness, arthritis in 3 or more joint areas, arthritis of the hands, it's symmetrical, rheumatoid nodules may occur. These are little bumps. You may see something called rheumatoid factor that shows up in the bloodstream, and then changes on radiography that you can see with X-ray. Well, how do we treat it? It is a chronic disease, so rest and therapeutic type exercises to strengthen the joints. In addition, to reduce the inflammatory response, steroids as well as non-steroidal anti-inflammatories can be given. And sometimes RA is treated with what are called disease-modifying anti-rheumatic drugs, or DMARDs. These are drugs that slow down the progression of the disease, and they have also created different biologics that antagonize the cytokines that are produced, so to hopefully keep them from being as active. If required, they can do surgery to change the angle of the joints and help reduce joint pain. All right, so the wear and tear arthritis, this is something that most people experience over time. It tends to show up more on weight-bearing joints. So we see changes that affect how the weight is distributed or carried in the joints, and we get degeneration. So we have aging, we have mechanical stress, people who have played sports and have done, consistent sorts of damage to their joints may see this earlier. And the cartilage cells, the chondrocytes, respond by releasing cytokines. Again, we see these destructive enzymes chewing up joints. We eat up the cartilage, we get surface cracks, we break the bone, and we have bone spurs. Osteophytes can show up as well. So you can see bone cysts, bone spurs, little fragments of bone that are dislodged. And again, happens most often and frequently in the weight-bearing joints, the hips and the knees, but it can also begin to show, and also the vertebrae. It can also show up in the shoulders and other places. So how does this feel? Well, the joints ache. It can be difficult to initiate joint movements after rest, so you're sitting still and it's hard to stand back up. You may hear cracking when the joints move. This is called crepitus. If you want to hear that, you can come near me and I will just move my neck and you'll hear crepitus. And I mentioned that the joints involved are a lot of the weight-bearing ones: hips, knees, cervical vertebrae. So we treat it with a history, a physical, and X-ray. There's really nothing you can do to reverse this. You can do like physical therapy or rehabilitation to strengthen the muscles around the joint to help prevent further damage. You can take medications to reduce inflammation, so like non-steroidal anti-inflammatories. You can get steroid injections to reduce the inflammation. And then occasionally surgery, a hip replacement, a knee replacement, a bunion resection, or you can just get in there and clean it out to try to reduce the pain and increase the functionality. All right, okay, we have a muscle disease. You're going to see this again with neuromuscular diseases, but muscular dystrophy, or MD, is a genetic disease. There are several different varieties of this. The one we're going to talk about is called Duchenne muscular dystrophy. They're all a little bit different in their transmission, but this is an X-linked disorder. All of them result in muscle degeneration that becomes debilitating. So the Duchenne muscular dystrophy impacts, so if this is your muscle here and we're looking at we've got a whole muscle, we've got muscle fibers, we've got the contractile apparatus, And what hooks the contractile apparatus to the rest of the muscle is a large protein called dystrophin. If this has a defect in it, the muscles contract, but that contraction is not carried through the whole muscle. So this leads to muscle degeneration, leading to disability. As I mentioned, the one we're talking about today specifically is Duchenne muscular dystrophy. It is an X-linked recessive disorder, so it's going to be more common in boys. Starts to show up around ages 3 to 5 as the boys or girls have difficulty walking, have skeletal muscle weakness. The muscle fibers die off and get replaced by fat and connective tissue, so sometimes the calves look enlarged and you would think it's muscle, but it's actually fat. And the skeletal muscles become progressively weaker over time. It's diagnosed using electromyography, which looks at the electrical contractions of muscle. A muscle biopsy would show abnormalities in the muscle fibers. And you can also do genetic testing before birth as well as after birth. Treatment would include physical and occupational therapy, use of orthopedic appliances, and eventually probably a wheelchair. There is no cure.